So continuing on, Matt Brittberg is back and going to talk about conservative therapy as well as evaluation techniques for repair methods.
Okay, being an orthopedic surgeon and to be called also a cartilage surgeon, it's a special task to talk about the conservative treatment of cartilage lesion, but it's a challenge and it's quite interesting that a way that we should focus more on in the future maybe. These are my disclosures again. Well, if you look upon soccer players, we could talk about the amateurs. They are hoping for relief of pain, they are hoping for a return of functionality and some sports participations, while the professional athletes, they want a fast return to the previous level and with as little damage as possible. So we have to think about different ways how to treat them. And if we are not doing a repair, we have to remember the repetitive exposure of articular cartilage to mechanical stresses could reduce and slow down the cartilage recovery. And also, you remember the threshold. The threshold is lower when you have an injury already there. We know that professional athletes have a high incidence of articular cartilage lesions. You see 35% compared to the normal population of 5 to 11%. So it's logical results of a high demanding professional career. Treatment of articular cartilage in the knee is still a challenge, whatever type of treatment we are going to use. And we have a large number of techniques that are available from these conservative measures through various types of operations, and finally groove factors and genetic techniques that are for the future. But the goal of conservative treatment is to reduce symptoms. We could count on a healing of the lesion, but many football players with symptoms giving a disability, they have a wish to delay the time of surgery. Even if I suggest a surgery, most often they want to delay the time for the surgery and do it after season or even after the career. So effective conservative treatment alternatives are asked for. We have different types of medical treatments like NSAIDs and analgesics. We have to reduce the weight in some of them. Rest could be one alternative, ice, canes, bracing, physical therapy, all well-known treatment for injuries of the joints. Nutrition could be considered with chondroprotective agents like glucosamine and chondroitin sulfate, omega-3. A lot of discussion about those treatments. Intra-articular injections like hyaluronic acids, viscosupplementation. However, to date, none of these treatment has proven that they could heal a cartilage lesion. They could reduce the symptoms for the patients. So one of the main important parts of the conservative treatment is certainly physiotherapy treatment with the restoration, first of all, of the passive range of motion, followed by a progressive resistance training program of the muscles that Barbara also talked about. With the full passive motion, you have influence on the synovial fluid, and you know the synovial fluid is important for the nutrition of the cartilage, and if you don't have nutrition to the cartilage, you will have a thinning of the cartilage layer, and by that easier to have injuries. So therefore, programs for articular cartilage lesions should include multiple methods to restore full symmetric range of motions. We have also the active range of motion that is important, and during active range of motion there is a decreased load on the articular cartilage compared to resisted range of motion. So you have also to think about where the cartilage lesion is located, if it's located in the patellofemoral joint, on the tibial plateau, or on the condyles. So active range of motion is used as an intermediate step between passive range of motion and active and resisted range of motion. And also isometric programs are of importance. why you should try to perform multiple angle isometrics away from the lesion to prevent static loading on the healing cartilage. So you really have to think biomechanically when using this type of physiotherapy in order to have a treatment of the conservative treatment of the lesion, but the same when you are treating the repaired cartilage. Open kinetic chain exercises are also important, but you should remember that large shear forces across the joint could develop when using this type of exercise. So avoidance of open kinetic chain exercise across the lesion is indicated, in particular slow speed, high resistance OKC exercises is believed to be negative towards cartilage. I think it's very important to press the importance of physiotherapy training in conservative treatment as well as after operations. Lack of enough physiotherapy training is one of the most common causes of non-improvement after musculoskeletal surgery, especially cartilage surgery. And I could cite the famous Wayne Gretzky, the ice hockey player. To become a world star, not only talent is counted, but massive training. From the age of 3 to the age of 12, I could easily be out there for 8 to 10 hours a day, Gretzky has said. Repeated coaching by a physiotherapist is important from start to get the patient into what I call internal training mode, training for life. That's important for these conservative lesions. We could also unload the cartilage lesion. We could use unloader braces. We could use unloader insoles. Kinesio tape is one of my favorites as well. There is also this type of treatment, pulsed electromagnetic fields, that Sorsi in Italy has investigated, and they found that treatment with PEMF aided the patient's recovery after arthroscopic surgery and reduced the use of NSAIDs and also the positive long-term effects. So that's one way that you could use along with physiotherapy training. But then you have regenerative biological treatments that you could augment the nature's normal response of repair in the joint. You could use hyaluronic acid injections, PRP, that we've heard yesterday about, growth factor augmentation, and cytokine modulations. If you look upon PRP, it's an autologous concentrated cocktail of growth factors and inflammatory mediators, and it may be used to activate, to form a matrix that could fill partly the cartilage lesion and get the lesion to be a little smaller. It has an anabolic effect on chondrocytes, on synoviocytes, and on mesenchymal stem cells. So have different effects also on inflammation and have some effect on the repair. But PRP therapy remains unpredictable owing to the significant heterogeneity among studies. And also, if you take PRP, it's a variation from day to day, from hour to hour, from individual to individual. So it's very difficult to regulate. There are some studies, not so many studies. This study by Lisa Kohn and co-workers looked upon osteoarthritic patient and compared it with hyaluronic acid treatment, and they found that they had better results in young and more active patients with a lower degree of cartilage degeneration. So that was not for cartilage lesion, it was for osteoarthritic lesions. NSAIDs are traditionally used using the Price principle of treatment after sport injuries. They have a modest role in treatment of acute injuries, but they have no harmful effects when used for a short period. But one could say that NSAIDs have a minor role, and in the short course you could use it to reduce the degree of inflammation and pain relief. The same is with corticosteroids, but corticosteroids could be negative when you expect a repair response, because, you know, repair is involved with inflammation. If you use corticosteroids, you could reduce the degree of inflammation and you have less inflammation and less repair. But for the short term, it could be used. Stem cells are other alternatives. Stem cells, you know, could be used in order to, by chondrogenesis, go into the chondrogenic pathway and become chondrocytes. They could be used to become bone cells and repair bone. But when used conservatively, they are used because they have anti-inflammatory effect and also trophic effect, so they could stimulate a repair by that, but not by repair themselves, but stimulating the synucleocytes and the chondrocytes to produce the right type of material. And today, for example, it's quite popular to take a fat tissue like a liposuction, and you take this fat tissue and you crush the tissue in a special machine, and you release the so-called pericytes, the cells that are growing on the vessels, and those pericytes are stem cells that could take part in the repair events. So we would expect a lot of studies in the future because this is already on the market in use, but very little is known about their real effect. So for me to treat patients conservatively, I have to look on the patients with the different types of symptoms. And if the patients have a degree of pain and movement disability, I certainly would go into the operative mode. But if the patients have no pain, just hydrops or swelling after sport, we may go into the conservative way. So it's a balance between conservative treatment and operations. This is an example of a patient. I had this patient 5 years ago. He was to get a professional contract in football for Espanyol in Spain. He had a lateral meniscus injury and a cartilage injury. So he came to me, but he had no pain. He wanted to continue football. He was not so eager for an operation. Because he just had swelling, we treated him conservatively and could get him back to play football. And now, 5 years later, he has got a professional contract with the Bosnian club. Still, you could say that there is a slight progression from 2010 to 2015, so there are ethical issues. What would happen if we had done an operation? Should it look the same? If we got him, if it stopped him to play football, would it look the same? So these are questions that we need to know more about. So we need studies on the natural cause of this type of cartilage lesion. A non-operative treatment is a non-restoration of lesion, but it might be a restoration of the joint homeostasis. Lesion restoration may not prevent a further deterioration of the joint into OA. So these are things that you have to consider. Furthermore, for the conservative treatment, body weight, body mass index, demand and functional need, the expectations of the patients, and the ability to comply with the rehabilitation that we need. Also that you get the patients to stop, for example, smoking. Then the other task was to talk about, well, we could just say that it's important for the patient to understand that the time is long, for the training is durable, and also that you have to have tolerance and patience for both the patients as well as for the treating surgeon using this type of conservative alternative. The other task was the evaluation of the repair tissue, and it's quite important in order to understand what way we are going to do, if we are going to do conservatively or if we are going to do the other way. One of the best ways for evaluating the cartilage is to do the arthroscopy. So in order to understand the type of lesions, we have to understand that there are different types of classification. And one of the most used classifications have been the outer bridge classification, but that is not measuring depth. So in order to know about repair, we need to look upon other types of classification. And one is the ICRS classification, where we look upon the depth, where you have the normal cartilage, you have fissure, which is degree 1. If you go deeper down into the cartilage, you have grade 2, which is less than 50% depth of cartilage. If you go further down to the calcified layer or to the bone, or even further down, you have grade 3, including also blisters. And then you have grade 4 when you go down into the osteochondral bone. These types of classifications could be used in a mapping system, so you know exactly where the lesion is, and you could follow the patient by MRI. There is also this classification by Cahill and Berg that could also be used. With the MRI, you could transfer this information. You could use the REST MRI score. You could use the Bondorf score, also another score to evaluate the repair, and also the progression of a conservative treated patient. You could take biopsies, less common today because you get very tiny portion of the repair tissue. You have to go down into the subchondral bone to see both of the bone and the cartilage layer. And then you have different types of stainings. You could see the type of repair tissue you have, and these are different types of histologic evaluation systems that could be used. MRI, if you have metal, it could be difficult to evaluate with MRI. You could then instead use CT arthrography that is quite useful to follow the surface of the cartilage and also what's happening in the subchondral bone. MRI 1.5 to 3.0 Tesla, and for research 7 Tesla are the ones that we are used. Because they are non-invasive, they could be reproducible, and they are very accurate. And there are different types of them that you could use to look upon the surface and the thickness, the information about the normal articular cartilage here, D-gamric about the protoglycan, T2 mapping collagen structures. And this is an example of a patient that has a cartilage lesion that 4 years later were examined by an MRI. You still see the lesion. You could evaluate it's filled up, but there's a reaction in the subchondral bone. And another one, you see an osteochondral graft quite nicely. You could follow the repair and the integration. So it's quite useful to follow the repair by that. There are also MOCAT score and Crook score that could be used more to have an evaluation and the result of your treatment. And you could get an evaluation about the quality of the repair. And here you could see a microfractured area, quite different towards the normal cartilage in a patient here. And in another patient, you will find that has been operated with a very large ICI, chondrocyte implantation. You see the bluish color. This is the graft, and this is the normal cartilage. So you could get quite a fair view how it looks like with this type of evaluation. But also, when you do the arthroscopy, you have to know, or you do the MRI, you have to know that there are different types of repair. Some are filling from below, some are filling from above. So there is this evaluation system that you could use together with the MRI to get a percentage of the repair. And if you do a drilling, if you do a microfracturing or abrasion arthroplasty, you fill from below. Also, when you have a scaffold like the one-stage scaffolds today, you fill from below, and it takes longer time, and that's important to remember, because if you do an osteochondral graft, you have a filling directly, similar with mosaicplasty. If you have ICI, you have semi-filling like that. So that's important to remember. And I thank you very much for your attention.